Hi, my name is Hannah Jackson, and I'm a PhD candidate in the SEMA lab here at MIT. And today I'm excited to talk to you about a new treatment method for patients with refractory epilepsy. So I'm sure most of you have heard of epilepsy, or you might even know somebody who's affected by it. It's defined as a neurological condition characterized by recurring seizures. It can affect anyone at any age, and it may or may not have an identifiable cause. What you probably didn't know about epilepsy, however, is that more people live with it than with Parkinson's disease, multiple sclerosis, and cerebral palsy combined. It's one of the most common neurological disorders affecting 65 million people, regardless of age, sex, race, or income level. The most common form of epilepsy is focal epilepsy, which is when the seizures originate from a specific area or region of the brain. It's also very difficult to treat, and in fact, a third of patients will not respond to oral anti-seizure medication, leading them to being classified as drug-resistant or refractory. That's a third of patients with uncontrollable seizures, leading to a significant decrease in quality of life and increased risk of sudden death. So why is this? Well, more anti-seizure medication is being developed now than ever before. And despite this, the number of patients with drug resistance has not changed. This is because all of these drugs suffer from the same problem: crossing the blood-brain barrier. So because of this barrier, many of these drugs are unable to reach their target in therapeutic amounts in the brain. In addition, many of these drugs cause significant side effects and systemic toxicity, which makes just increasing the dose impossible in many patients. If we were able to deliver these drugs locally and bypass the blood-brain barrier, we provide better seizure control with little to no side effects. This is not done, however, and the current gold standard for treatment is surgical resection, which is when the area of the brain containing the seizure focus is removed. This highly invasive procedure is heavily underutilized, however, and to demonstrate this, roughly 3.4 million Americans have epilepsy. About 2 million, or 60%, will have identifiable seizure focus. From there, about a third will have drug resistance, and of these patients, only 4,000 will receive resection surgery every year. The rest will forego this procedure because it's too invasive, has significant comorbidities, or the lesions are in an inoperable location. These patients would benefit from a new treatment method that was less invasive than resection and could target the seizure focus with minimal to no side effects. So for these patients, we propose a refillable infusion system to deliver anti-seizure medication, or ASMs, directly to the seizure focus. So our device would consist of a micron-scale neural implant coupled via a catheter to a subcutaneous battery-powered micropump and drug reservoir that would allow for continuous and programmable drug delivery. By bypassing the blood-brain barrier and delivering these drugs locally, we can achieve much greater seizure management with less off-target effects compared to systemic delivery. We would also deliver much smaller doses than what is delivered systemically. Our device can also be implanted using standard and simple techniques that are already used in the clinic, and this could even be done as an outpatient procedure. And because we're using already approved ASMs, FDA regulation is simplified, and we would create a device master file that would be submitted with each new ASM used. Currently, there are no devices on the market that can chronically deliver drugs to precise locations deep within the brain, making this device game-changing. Our implants have already been developed in the lab, and their drug delivery properties have been characterized in mice, rats, and even monkeys. We've shown that we can infuse drugs directly through our device, and we've even coupled it to a subcutaneous pump to deliver drugs chronically in animals. So our implants are composed of borosilicate capillaries, and they're incredibly tiny, as you can see by this comparison of our cannula next to a human hair, my hair. And because they're so small, they actually reduce tissue reaction and scarring, which would normally cause implants in the brain to clog. So through our animal studies, we've shown that we can deliver drugs consistently and repeatedly for up to a year post-implantation. So this neural drug delivery device has been in development in the SEMA lab for over 10 years now, with 5 scientific publications and 2 patents for the technology. We're currently collaborating with the University of Utah's anticonvulsant drug development program to make use of their cutting-edge animal models. So we're working with Utah to use our devices to deliver ASMs in a mouse model of focal epilepsy. We've already traveled to Utah multiple times and integrated our device into their current animal models. And preliminary data has actually shown that we can infuse microliters of drugs to acutely suppress seizure activity in these animals. So moving forward, we've already begun testing our device in a mouse model of focal epilepsy. Normally, we would then move to a larger animal model, such as monkeys, and then finally humans. However, we've already begun conversations with prominent international research institutions talking about early phase 1 clinical trials in humans by 2024. So the goal of these trials would be just to study the effects of small local ASM delivery on seizure activity. This data would provide invaluable preliminary data to support our device development moving forward. So our device could revolutionize how epilepsy is treated by providing a treatment platform for millions of patients with refractory epilepsy who currently do not have one. The age for ASM drug development is ending, but the age for drug delivery has just begun, and we're just now scratching the surface of what's possible with our device. So our ask is that we're looking for possible collaborators who are interested in talking about early clinical trials, as well as clinical advisors to help guide our product development and target market. So if you're interested, please talk to me, and thank you for listening to my presentation.